שידבר על Invasive Procedure Planning in DOAC Stations.
שלום, תודה רבה, ונראה שזה בסוף היום, אולי עם הסכמתכם אני יכול לדבר באנגלית, להער את הקבוצה. Yes, okay, here we go. So, thanks for inviting me. Case is a 69-year-old woman who has a past medical history of hypertension, diabetes, a lot of the risk factors, paroxysmal atrial fibrillation, stage 3 chronic kidney disease. She presents Thursday morning, Yom Hamishi at 8 o'clock with a near syncope, and EKG shows she's in a complete heart block with a ventricular rate of 27 beats per minute. Blood pressure is low. She's symptomatic. A temporary pacemaker is put in. She has a Chad's VASC of 5, and her medications are apixaban, which 5 milligrams twice a day, which she took just an hour before presentation. Lipitor, bisoprolol, ramipril, and aspirin. And the question is, it's Thursday, it's before the weekend. The EP lab is open for, is available to put in a pacemaker. The question is, how would you address the situation given her anticoagulation status? Would you hold apixaban, wait the weekend, and put in the pacemaker on Sunday? Would you hold apixaban, start low molecular weight heparin, and then stop it before the procedure after the weekend? Would you put in the pacemaker that same day, not give the apixaban that night, and then restart it the next day? Or would you do the pacemaker implantation and continue with her apixaban as usual? Ish. Basically, hold and bridge, continue and hold, or just continue and continue. So most people would proceed with the implantation and not give it later that night. Okay, so we'll go through. So my topic was actually perioperative DOAC management for invasive procedures, which is quite a broad topic, not specifically devices. So I'm going to go through primarily devices, but then talk about procedures in general. Okay, first question related to anticoagulation. Does bridging really help? Does a bridge keep us over troubled waters? Historically, recommendations if someone had a mechanical valve or atrial fibrillation, the recommendations were before a procedure were stop those before the DOAC era was to stop the warfarin 5 days before, give a heparin bridging, preferred low molecular weight heparin, and then proceed with the procedure, stopping heparin either 4 hours if it was IV heparin or 24 hours before the procedure if it was low molecular weight heparin. For devices specifically, the major concern was pocket hematomas. Pocket hematomas can be painful, result in infection, require extraction if the pocket opens. It's a primary problem during device procedures. How people used to handle anticoagulation was very varied. Depending on the situation, you can get a number of different possibilities, different answers. Some people just stopped the Coumadin. Some people gave low heparin beforehand. Some people gave both before and after. Some people just lowered the dose of the warfarin. A lot of variability. Back in 2013, came out a BRUISE trial, which was a randomized trial that actually checked continuing warfarin versus heparin bridging. The primary outcome was clinically significant hematoma. That was defined as a hematoma in the pocket requiring prolonged hospitalization, stopping anticoagulation, or some type of intervention because of the hematoma itself. Primary outcome, significant decrease in hematoma from 16% in the heparin bridging to the surprise of many perhaps, that if you continued the procedure on anticoagulation on uninterrupted warfarin, there was a significant drop to 3.5% of clinically significant hematoma. This was despite a procedure that was done with an INR of 2.3 therapeutic levels of anticoagulation. And in the sub-analysis, it really didn't matter what the characteristics were of the procedure or the patient. Continuing Coumadin was the favored procedure. Meta-analysis subsequently, in terms of the concern for stopping warfarin and whether or not you would bridge, it didn't matter what you did, whether you bridged, whether you stopped warfarin, or whether you stopped warfarin and didn't bridge, the actual stroke rates were quite low. And cumulative data of over 5,000 patients, the stroke rate was 0.4% perioperatively. The concern for hematoma in follow-up of these patients in the bruise control infection trial was that those patients who did develop a clinically significant hematoma had a 7 times more likelihood of developing a clinically significant infection of the system, which required extraction, prolonged antibiotics, and complicated the patient's outcomes. Consequently, as a result of the bruise trial, recommendation for device procedures going forward was to not do bridge. Bridge was taken away from any algorithm for device implantation. In addition, because we're talking about procedures in general, what to do with NOACs, just again to relay the message, the bridge trial, which was with Delta parent, also found that bridging versus no bridging for general surgical procedures, bridging also significantly raised the risk of hematoma. Sorry. Now moving forward to the DOACs, the initial data from a sub-analysis of the Relay trial, which compared dabigatran at the 2 doses with warfarin, found that the subcategory of patients that did undergo a device procedure during the Relay trial had significantly, they had similar rates of pocket hematoma. But if you looked at the sub-analysis, those patients that had warfarin with bridging, 10% of them developed a pocket hematoma relative to only 2% of the other patients. So bridging is bad. Now the question is, those previous trials were about whether or not what to do with the Coumadin, whether to stop or to continue. So now the question, since bridging is taken out, what do you do with the DOACs? Do you continue or do you stop? Comes the Bruise Control 2 trial, which we had the opportunity to participate in. This was a randomized trial comparing device implantation or replacement with the 3 types of the new oral anticoagulants. And one arm was continuing, including the day of the procedure, versus stopping at least a 24-hour window prior to the procedure and resuming 24 hours at least after the procedure. Important that dabigatran, because of its renal clearance, depending on the renal function, dabigatran could have been stopped up to 48 hours prior. In terms of the risks of stopping anticoagulation, these are procedures that were done on people with a CHA2DS2-VASc of quite high, close to 4 in both arms. Now, to say continued anticoagulation, continued DOAC therapy, what does that really mean? It means that people got their procedure, including the morning of, and continued the DOAC, including the night after that same day after the procedure. So if you look at the last preoperative dose and the first postoperative dose, you see it's a 12-hour across the board, irrespective of renal function. They all got it the day of the procedure, both morning and night. If it was a BID dosing or a rivaroxaban, they got it that night after the procedure the same day. This was a trial that was supposed to enroll over 800 patients to determine a 40% difference. After 600 patients enrolled, The steering committee decided to stop the trial early because of futility. There was no difference in the outcomes. They anticipated that one would have to enroll over 7,000 patients to determine a difference in the outcomes. And the overall clinically significant hematoma rates was only about 2% in both arms. It did not matter whether you continued or whether you stopped. The point being, and in the discussion basically said, you can decide what you want to do. The trial could not conclude which was the better protocol, so you have the choice. Meaning if someone comes emergently and you need to go along with the procedure, you can go ahead safely and do the procedure. If you prefer not to and it's an elective procedure and you feel more comfortable, you can go ahead and stop it for a day prior to the procedure and feel comfortable that both outcomes will be similar. A combined analysis of both the BRUISE 1 and 2 trials basically showed that there was no difference in the continued DOAC arm as compared to continued warfarin arm in terms of hematoma rates, but that if you combine, in both of these trials, if someone was on aspirin, it was continued. If someone was on another antiplatelet, it was up to the operator. And so the combined analysis of these two trials was that if someone is on both a DOAC and an antiplatelet, of course, it increased the risk of a hematoma up to twofold. Now that was in terms of devices. Moving forward to ablations, there's a recent analysis of 3 trials that checked DOAC therapy and AF ablations. 3 trials are Venture AF checking rivaroxaban, dabigatran in recircuit, and apixaban in the XFF-NET trial. These were continued DOACs versus continued Coumadin. The Venture AF was a relatively small trial of only 250 patients. It was the first one published. It was not looking for statistical significance between the 2 arms, just to get some data out published. The recircuit was looking for non-inferiority, and probably the most important results of these 3 trials in terms of the outcomes was that, 1, all 3 trials favored continued NOAC therapy, and that the recircuit trial, which checked dabigatran, showed a significantly decreased risk of major bleeding complications relative to continued warfarin. Just to make a point, like when people are concerned, well, doing these procedures as AF ablation, it's an invasive procedure. Of course, you're puncturing the groins, you're crossing over to the left side. What do you do if the person starts bleeding? I think all of the pericardial tamponade rates, which were quite low numbers relative to Coumadin, no one needed to be reversed. Pericardial drainage was enough to take care of the problem. No one needed any reversal agents of their DOAC. So recently came out a statement. It's not quite guidelines, but it's a statement paper from the European Heart Rhythm Society about how to deal with, in general, these new oral anticoagulations across the board. Number 1, checking for levels as a general rule is not recommended. Checking PT levels or PTT levels is not recommended because it's very hard to correlate between activity and bleeding risk. There's some idea that if the PT is normal, that means that at least that the level of the drug is not supratherapeutic, but normal doesn't rule out risk of bleeding. In terms of what to do with dosing prior to invasive procedures in an elective situation, it's the 1 to 2 day rule. Basically, if someone has a planned procedure, you can stop the DOAC the day prior. If there's an issue of renal function, then you can up it to 2 days, but it's basically 1 to 2 days prior to the procedure and restarting 1 to 2 days after based on renal function overall. Now, it's all relative to what the risk of bleeding is and what is the definition of minor bleeding, major bleeding, or minimal bleeding. Basically, minor bleeding risk, dental procedures, skin procedures, and endoscopy without any planned intervention or biopsy. What is considered a low bleeding risk procedure? Endoscopies with biopsies. Here, the catheter ablations primarily on the right side, where you're not crossing over. Non-coronary angiography, and pacemaker implantation, where you can choose to stop or continue the DOAC therapy prior to the procedure. In terms of what's considered a high-risk bleeding category, complex endoscopies, where you're actually going to be doing a polypectomy, but importantly, spinal taps, epidural. So the recommendation is 5 half-lives of the DOAC. You should wait before proceeding with the lumbar puncture. Obviously, the thoracic surgeries and bleeding risk is high, but just as a separate category, though, those ablations that you cross over to the left side, it's a twofold problem. There's a bleeding risk, but there's also a hypercoagulability risk. And there are centers, this past 2 days, we spent 2 days with physicians from Brussels and England, and those patients that come for an AF ablation, not on anticoagulation, if they have a low CHADS-VASc, they will get their first DOAC dose 4 hours before the AF ablation procedure, with the idea being that that afternoon they will be at therapeutic levels after the procedure already, because of the hypercoagulable risk following an AF ablation. And they don't worry too much about the bleeding risk during the procedure. Just as a note for AF ablation procedures, those who are on rivaroxaban, you may need higher doses of heparin during the procedure to get that ACT to a therapeutic level. But it turns out that the rivaroxaban ACT levels end up being a little bit lower than dabigatran or apixaban. You end up being closer to 300 as opposed to 350. But it doesn't necessarily have any significance clinically. They also provide this table in terms of someone who really needs a visual assistance on what to do with their pills. I find this very confusing. But the point is, oops, sorry. The star is the surgery date. The day before, you have choices of stopping and continuing for the low-risk bleeding procedures, and for the higher-risk bleeding procedures, a couple of days prior to stop it. Probably the most important thing about this graph is no bridging and no bridging. Bridging is out in all the arms. Now, the emergent procedures, what to do with DOACs. It depends on the circumstances. If someone requires an immediate procedure, and they also have bleeding, or they require reversal of the NOAC, then that at least has to be considered. It has to be, depending on the circumstances, if there's trauma, if there's multiple fractures, every situation is different. So that's when you would consider reversing the NOAC and proceed with the operation. Checking for factors is part of the protocol. How it influences, it's a question. If it's an urgent procedure, meaning you can actually wait even 10 hours, 8 hours, 12 hours later that night or the next morning, if that situation allows, you don't necessarily have to reverse, because you presume by then the DOAC level will be low. If it's a procedure that can wait X number of days, then reversing the agent really isn't on the table. So in terms of the three circumstances, if you have a mild bleeding situation versus a non-life-threatening major bleeding, the reversal agent for dabigatran is really reserved when you're talking about life-threatening bleeding and a procedure needs to be performed fairly imminently. Just a note about in terms of giving the PCC and the protamine, the concentrate, giving the APCC can actually give some increased risk of clotting. And you'll notice that fresh frozen plasma is not listed anywhere. Fresh frozen plasma, if you give fresh frozen plasma, it'll get used up by the serum DOACs. It will have no effect, and it's a large volume infusion for the patient. So it's really not recommended to give fresh frozen plasma. For PCI, for patients who need to undergo PCI, depends if it's elective or emergent. Yep. It depends if it's elective or emergent. Elective procedures, you can just hold it the day before. You don't have to worry about increased risk of stroke because the stroke risk is so low. If someone comes in with a non-STEMI and it's a non-urgent PCI planned, you can stop the DOAC and you'll give heparin, let's say over the weekend, or there's a couple of days until the procedure is planned. You should give the heparin anyway, not because of as a bridging concept, but more to treat the acute coronary syndrome. If someone comes in with a STEMI, if there's no option other than fibrinolysis, then levels of the drug should be checked, and fibrinolysis should not be given unless the NOAC level is low. Preferred is, of course, primary PCI with a radial access. And just finally, as a final invasive procedure, if someone needs a cardioversion, pretty much the same concept as what we would do with Coumadin. If it's within 48 hours, you can give a dose beforehand and go ahead with the cardioversion. If it's more than 48 hours, you can go ahead and start it, but you'll need the TEE. If they've been on it for at least 3 weeks, you can go ahead with cardioversion without TEE. Thank you.
Thank you very much, Eddie. Since we're behind schedule, we'll move on to the next topic.